Thank you. First, I'd like to thank Simona and the organizing committee for kindly inviting me here. This is my first time in your National Congress, but about 6 months ago, we were here in a Balkan meeting to see the nice city of Cluj. So, my talks will be about the new criteria in ANCA-associated vasculitis. Then I'll look at the approach to the management of GPA and MPA, and finally, briefly, to the management of eGPA. Now, core clinical features of ANCA-associated vasculitis differ. In MPA, it's mainly renal and lung disease. In GPA, in addition to them, there is ocular disease and ear, nose, and throat diseases. And eGPA, as you know, starts usually with asthma and also having features of neurological and cardiovascular involvement. Now, in the criteria that I'll mention, management guidelines, there is always the term of organ life-threatening or mild disease, non-severe disease, and the major severe disease. Now, potentially organ life manifestations are, as you can see, glomerulonephritis, pulmonary hemorrhage, meningeal involvement, CNS disease, orbital disease, cardiac, mesenteric, and peripheric neuropathies. On the other hand, generally, upper respiratory tract involvement, nasal and paranasal disease, skin disease, myositis, and sometimes mild pulmonary nodules and episcleritis can be accepted as the non-severe, non-organ life-threatening disease. Now, recently, ACR and EULAR defined a new classification criteria for ANCA-associated vasculitis after some like 30 years. There was a need for the change, and the need comes from two major issues. First of all, when these criteria were developed, there were no ANCA around, or just newly started and not included. And for that reason, PAN and MPA in our daily terms was different. Now, when we apply this criteria to the new set of patients, the specificity is still quite good. However, the sensitivity ranges from 28 to 65%. So there is definitely a need for better classification. And this came from the DCVAS cohort with patients from over 100 centers in 20 countries. This is the largest ever vasculitis cohort with approximately 7,000 cases and comparators. In this group, GPA and GCA are the largest patients. And here you see the classification criteria. For time reasons, I'm not going into the detail of it, but there is one clear issue there. And that these classification criteria is not for daily use and diagnostic purposes. First of all, alternate diagnosis mimicking vasculitis should be excluded, and then you will make you will apply this criteria when a diagnosis of small or medium vessel vasculitis has been made. So definitely you'll make a diagnosis of, for example, a small medium vessel and try to differentiate between IgA, ANCA-associated vasculitis, or cryoglobulemic vasculitis. So these are not diagnostic criteria and can only be used in clinical studies. And the performance characteristics, as they are applied according to each other, are quite good, over 85% sensitivity and around 94 to 99% specificity among the different vasculitis patients. Now, if you look at the management of GPA and MPA, last year, EULAR published the new guidelines. And here, as you see, the disease is differentiated into non-organ life-threatening and organ life-threatening. And in the non-organ group, start with rituximab preferably, or methotrexate or MMF, combined with glucocorticoids is suggested. For the severe group, it's mainly rituximab or cyclophosphamide. And there is also the avocapans placed there that I'll come back later on. After 4 to 5 months, glucocorticoids are decreased to 5 milligrams per day, and then after the remission, will pass to maintenance treatment. Now, this is somewhat different from the 2021 ACR criteria. And one of the differences is that in non-severe GPA, ACR put not rituximab, but methotrexate with glucocorticoids as the first line. And for severe group, rituximab over cyclophosphamide as the first choice. Now, in which patients we should choose rituximab or in which other cyclophosphamide? For most of them, it seems rituximab is better because for children and adolescents, premenopausal women and men concerned about their fertility, frail older adults for infection risk, relapsing disease, and the PR3 ANCA positive disease seem to have a better response and safer with rituximab. For cyclophosphamide, it is still the physician's choice in difficult cases, and also this KDIGO, renal physician's global guidelines, suggests that in severe cases over 4 milligrams per deciliter creatinine levels, a combination of cyclophosphamide and rituximab can also be considered. And this comes from the studies from UK, where the patients with severe renal failure or under renal replacement therapy, half of them, with high levels of creatinine and the GFR around 9, are given around 3 grams of cyclophosphamide in 12 weeks with 2 doses of 1,000 milligram rituximab with a fast prednisolone reduction. This is not a routine regimen yet, but they suggest that 36-month survival is around 85%, and it seems to be better than the historic cohorts. There is another option for remission induction, which is not mentioned too much, but important for countries like us, where the cost is important, that mycophenolate mofetil doesn't seem to be non-inferior compared to cyclophosphamide in this randomized study from UK, where 132 patients with, however, no severe renal failure were given either MMF or cyclophosphamide. And at the end, you see that around 75% reached the primary remission in around 250 days. Now, plasmapheresis, the biggest discussion in these days. As you know, a very big study published 3 years ago, PEXIVAS, over 7 years in 704 patients, where 2 issues are addressed. One is whether to give routine plasmapheresis or low or high dose steroids. If we look at the plasmapheresis part, in fact, at the end of 6 years of follow-up, as you see, there is no change between in the rate of death or end-stage renal kidney failure, whether the patient gets plasma exchange or not. But there are some nuances, and it seems it comes from the meta-analysis of 2 major studies, MEPEX and PEXIVAS, that although mortality is not affected, the rate of end-stage renal failure decreased with plasmapheresis, however, with the cost of increased infection in 12 months. And for this reason, the recent a practice guideline published in BMJ suggests that in the patients with moderate to high renal failure with a creatinine approximately over 3.5 and with an end-stage renal kidney risk of over approximately 10%, routinely plasma exchange is suggested, but it's not suggested in patients with a lower kidney failure and in patients with pulmonary involvement, which is not shown in the clinical study. If we look at the steroid side, high and low doses of glucocorticoids are used in PEXIVAS, and as you see, the dosage starts in both groups from 1 milligram per kilogram per day. However, very fast decrease to 30 milligrams and then less than 10 milligrams in 12 weeks in the low dose group. Again, like the general assessment of the plasmapheresis, reduced dose and standard dose cases have the same rate of around 28% death or end-stage kidney disease. So we can definitely start with 1 milligram per kilogram, but fast decrease the dose of steroid, which is in fact affects the rate of serious infections. There is another study came out 2 years ago, an important one from Japan, where they randomized 140 patients in standard rituximab treatment to low dose 0.5 milligram per kilogram stopped in 5 months, and the high dose 1 milligram kilogram, which is continuing after the 5th month. And here, as you see, BVAS and CRP decrease in the same level, and the only differences and the remission rate was similar, around 70%, and the only differences were in serious infections, which was 11% in the reduced dose and 29% in the high dose. And also, diabetes was lower in the reduced dose. So with this data, we can definitely say that starting and continuing with a medium, low to medium glucocorticoid dose is safe and effective in ANCA-associated vasculitis. And now, avacopan. When we look at the pathology of ANCA-associated vasculitis, until now, we aimed at B cells, T cells with abatacept, and to various aspects of the immune response with glucocorticoids. Now, we have a C5a receptor antagonist, which can block the activation of neutrophils. Avacopan is an oral agent, easy to use, and the major study came out in New England in 2021. In this study, just to show you that both study groups had the standard treatment, mainly with rituximab and parenteral cyclophosphamide, and about 2/3 of them were newly diagnosed patients. Now, the interesting part of the study, avacopan is not aimed to replace rituximab or cyclophosphamide, the second drug, but aimed to replace glucocorticoids. That's a new approach. And here you see that with this approach, with a fast steroid decrease in 2 weeks, the rate of sustained remission at 1 year was quite similar. In fact, even better in avacopan compared to prednisolone, 54 to 65%. And it seems that the relapse rate was lower. And with this approach, the patients got lower glucocorticoid, avacopan 1,349 milligrams versus prednisolone 3,600 milligrams. And avacopan seems to be safer in terms of opportunistic infections. A further analysis of this study was done recently with the same group, only looking at the patients with severe renal failure, GFR below 20 milliliters per minute. And it seems that avacopan improved GFR better than the glucocorticoids. And the side effects are, again, quite similar. So avacopan is a new option that we can use to decrease the glucocorticoid dose. Whether it can replace rituximab or glucocorticoids as the first-line agent is still not clear because the study is not designed for this. Now, remission and maintenance. Now, the factors associated with relapse in ANCA-associated vasculitis can be divided into baseline factors after diagnosis and treatment factors. Diagnosis of GPA with the PR3 ANCA subgroup is definitely a major risk factor for relapse. Lower serum creatinine, interestingly, more extensive, especially ear, nose, and throat disease, are also related to baseline factors associated with relapse. History of relapse and the ANCA positivity at the end of induction, also the rise in ANCA titers during remission are important. And interestingly, some data show that lower cyclophosphamide exposure can be related to higher relapses. Is it possible to have a drug-free long-term remission in GPA? This is defined as sustained remission off therapy, without therapy. And in the major French study, it was shown that it's only about in 25% of the patients after 6 years. However, the characteristics of this patient small subset is important because it seemed that similar to the relapse rate, number of cyclophosphamide infusions is important in terms of sustained remission. And also, use of rituximab in the remission instead of azathioprine or MMF is related to a better long-term course. So, what should we do in remission? This is the EULAR guideline suggesting that rituximab should be the first choice for up to 1 to 2 years, but azathioprine or methotrexate can be used. And then first glucocorticoids or avacopan is stopped, and then defining the individual relapse risk with comorbidities and the patient preference, we should decide on whether to continue or stop the maintenance treatment. I should say that although I look at different factors, I never stop the biologic or conventional immunosuppression after 24, even to 48 months in my patients because, as you know, there's a very high risk of relapses in these patients. Which drug to use in the remission? Rituximab is preferred in relapsing disease, PR3 ANCA disease, frail older adults, glucocorticoid, when glucocorticoid sparing is important, and when there is azathioprine allergy. Azathioprine is preferred usually when there is a contraindication or cost issues with rituximab. And this is mainly low IgG levels, hypogammaglobulinemia, and in some cases, hepatitis B exposure. First of all, we can use rituximab in lower dose than the conventional studies. This is the main RITSAN-2 study comparing 2 grams every 6 monthly to 500 milligram 6 monthly rituximab doses, and the remission rates are exactly the same. So definitely, especially when we think of the cost and infection issues, we can use lower rituximab doses every 6 monthly, and we are mainly doing it this way in these days. However, hypoglobulinemia is still an issue. And it's in up to 4 years' time, significant proportion of the patients have some degree of hypoglobulinemia, but only IgG levels are seem to be clinically important. Now, when we look at how infections are associated with this issue, definitely infections are more related to hypogammaglobulinemia. However, the severe infection rate is not different. And this is reflected in the IgG replacement therapy from David Jane's group, that the total level of infections decrease with IgG replacement, but the severe infections stays the same. So, what is suggested? First of all, IgG replacement should be assessed in patients with major risk factors for hypogammaglobulinemia, low pretreatment IgG levels, and especially previous or concomitant, especially cyclophosphamide use. These two factors affect hypogammaglobulinemia levels. However, low IgG levels are not a direct contraindication for rituximab treatment. IV replacement therapy should be taught in low IgG levels with serious, persistent, unusual, or recurrent infections, and if there is an insufficient response to antibiotic prophylaxis. IgG starting dose is suggested to be 0.4 grams per kilogram per month with a duration up to 12 months. There is a second way of decreasing the infections, sulfamethoxazole prophylaxis, and recently it was shown that severe infections are less in patients routinely getting this combination. For that reason, ACR suggests that for patients with GPA-MPA, in both patients receiving rituximab or cyclophosphamide, trimsulfa prophylaxis is suggested, maybe not only for pneumocystis jirovecii pneumonia, but also to prevent the whole infection rate. So finally, approach to the management of EGPA. Now, active EGPA can also be assessed as both non-organ life treating or organ life treating. Non-organ life treating, as you know, is mainly goes with the asthma attacks with mild courses of skin or renal involvement. In these patients, we have a new group of treatment, anti-IL-5 treatments, and starting with mepolizumab with the clinical studies seems to be feasible. However, the dose is a bit of this discussion, because 100 milligrams standard use in asthma therapy is not sufficient. The dose should be 300 milligrams, and new agents are on the way. For organ life treating severe disease, EULAR recommends cyclophosphamide, but also puts rituximab as an option combined with glucocorticoids. Again, if there is no remission, you'll consult an expert center suggested. In remission, continue with azathioprine, methotrexate, mepolizumab, or rituximab. Mepolizumab also can be taken in severe cases when there is complete remission. After sustained remission is reached, again assessing individual relapse risk, comorbidities, and patient preferences affect whether to continue or stop maintenance treatment. But we know that even under treatment, especially mild asthma relapses are frequent. For that reason, completely stopping all immunosuppressives in 24 to 48 months is difficult in ANCA-associated vasculitis, and especially EGPA. So the take-home messages: rituximab is preferred more in GPA-MPA for remission induction in these days. Plasma exchange is still suggested in patients with high end-stage renal failure risk. However, whether it should be used in severe pulmonary disease with hemorrhage is not clear, not supported with the Pexivas data. There is no difference in using whether high or medium dose methylprednisolone as a remission induction. In patients with high end-stage renal failure risk, rituximab with low-dose cyclophosphamide might be the initial therapy. MMF can be an alternative in remission induction in GPA-MPA, especially when both rituximab and cyclophosphamide is intolerated or contraindicated. And mepolizumab can be an alternative in EGPA. For remission maintenance, rituximab 500 mg 6 monthly can be sufficient. Cyclophosphamide in remission induction may decrease relapse risks, but we know that it increases hypogammaglobulinemia risk in addition to other long-term malignancy effects. IG replacement therapy decreases the infection risk, but mainly the general infection risk. The serious infections do not change much. And although I didn't talk, follow-up for comorbid disease is getting more importance in EAV as the patients are living longer, such as cardiovascular events, metabolic syndrome, osteoporosis, and malignancy. All are shown to be increased compared to the general population. Thank you.